Hello, I'd like to thank SMRI for the invitation. Today I'll provide an overview of the technical advances in carotid vessel wall imaging with a focus on novel quantitative approaches. The current standard for assessing carotid atherosclerosis is the multi-contrast MRI technique. It typically involves TOF MRA, MP-RIDGE, and 2D TSC with different contrast weighting, as shown in this figure. Later study also found that contrast enhancement in conjunction with T1 weighted images can enhance the appearance of fibrous cap and surrounding tissue, therefore allowing the detection of large lipid core. Despite being well validated over the years, multi-contrast MRI has yet to become the clinical routine. In my opinion, one of the main limitations is the qualitative nature of the imaging. The plaque signal intensity is often compared against the SCM muscle to determine its relative signal intensity. This approach is confounded by individual anatomy differences and coil sensitivity profile, as well as any variation in the reference itself. Therefore, qualitative evaluation based on relative signal intensity relies heavily on the reader expertise to properly interpret the results. It also limits the inter and intra-observer reproducibility and makes it more difficult to compare results between patients and time points. The work by Raman et al. Was one of the first quantitative imaging studies of carotid plaque using T2 star mapping. They found a significant decrease in T2 star in the symptomatic patients compared to the asymptomatic ones. And they later also found that ex vivo data that the symptomatic plaques are associated with higher amount of ferritin-bound iron, which was sensitively assessed using the quantitative T2 star mapping. Bessiali et al. Showed the feasibility of using multi-echo spin-echo sequences for 2D T2 mapping. The sequence has the exciting pulse followed by a train of refocusing pulses, and the moment of the phase encoding gradients is the same along the pulse train, and the signal from consecutive echoes is encoded as lines in the independent K-spaces. Those K-spaces data can later be reconstructed into images at different TE, and then can be fitted on the mono-exponential T2 decay curve for T2 mapping. A later study from the same group reported that the lipid core detection based on the T2 mapping showed a very good correlation with histology, and also has shown in this complex plaque example on the left, the IPH, fibrous tissue calcification, and also lipid can be well matched with the T2 map. On the right, they showed the lipid area detected on T2 map has a strong correlation with lipid area on histology. The recent work by Keith Vanson et al. Extend the work of T2 mapping to 3D using a stack of stars TSC pulse sequences with student random radial view ordering. This view ordering scheme is chosen such that an undersampled 3D volume is acquired at each echo time. So this allows the reconstruction of the 3D volume at multiple echo times and subsequently the generation of T2 maps. So on the right is an example of dark blood T2 weighted images of the carotid vessel wall acquired using this technique and the corresponding T2 map generated from the same slab. The work by Cullen et al. Showed the feasibility of a simultaneous T1 and T2 mapping in 3D using separated gradient echo sequences. So the blood suppression as well as the T2 weightings is achieved by IMSDE pre-pulse complex, and subsequently the acquisition is performed using a segmented spoiled gradient echo readout. So 4 combinations of flip angles and T2 prep times were used, and the T1 can be estimated from scans with different flip angles, while the T2 can be estimated from scans with different T2 prep times. This technique can provide nice joint T1 T2 mapping in 3D. However, it does require separate scans, which necessitates the need for image restoration, and also the dual flip angle approaches requires separate B1 mapping. Xi et al. Developed an interesting method for 3D T1 mapping of carotid vessel wall. And in this schematic drawing on the left shows this so-called goal snapped sequence. So after our inversion recovery pulse, a 3D golden angle radial acquisition is used to sample the entire inversion recovery process with a small flip angle and the gradient echo train. And then a sliding window reconstruction was used to reconstruct 3D volumes at different TI time for T1 fitting. And the graph show a simulated signal recovery curve of intraplaque hemorrhage at short T1, vessel wall, and also blood at long T1. 5 selected images along the inversion recovery curve were reconstructed from the gold snap data with the corresponding inversion time shown at each image. In the estimated T1 map, the arrowheads indicate IPH regions with reduced T1 at about 300 milliseconds compared to the T1 of around 1000 milliseconds in the surrounding region. They also compared the data from 11 subjects, a total of 110 sections, and showed that the minimal T1 within the sections that contains IPH was significantly lower than those sections without IPH. In our group, we have developed a joint T1, T2 mapping technique with multi-contrast carotid imaging. The sequence design includes a backbone of flash, small flip angle readout chain interspersed by different preparation modules, including the inversion recovery pulses and also T2 prep pulses with different durations. These pulses generate different contrast weightings, and together with the flash readout chain, generate a range of combinations of contrast weightings. So we developed the QMesh technique based on the MR multitasking framework. By taking advantage of the low rankness of the high-dimensional image data, we were able to use a tensor formulation to separately reconstruct the spatial and temporal basis functions. The resultant images are a 5D matrix with both the T1 and T2 contrast dimensions along with the spatial dimensions. Since we can generate a 3D volume at every single time point on the signal evolution curve, we can pick all the best contrast weightings that are useful, and also we can also fit for the T1 and T2. So this is the example data set from a single QMesh scan of 8 minutes. It provides a comprehensive evaluation of evaluation that includes the bright blood MRA, dark blood vessel wall imaging, T1 and T2 weighted images, as well as the maps. So this is an example of QMesh data in a patient with a potential lipid core in the carotid arteries. The conventional T1 weighted post-contrast images showed a typical lipid core appearance surrounded by enhancing fibrous tissue. The QMesh T1 map showed a decreased T1 at around 900 milliseconds and also decreased the T2 at around 35 milliseconds. This is a different example. This patient has IPH, as confirmed by histology, and on the QMesh T1 map, the region within the plaque has a very short T1 at 400 milliseconds, and the T2 was at 30 milliseconds. This is a scatter plot of all the observed plaque components in our preliminary clinical cohort in the T1, T2 space. we can observe a clear pattern of clustering of ROIs with the same composition. And this shows the feasibility of potentially an automated plaque phenotyping method based on T1 and T2 values. This is work by Kim et al. To use diffusion weighted images for carotid plaque characterization. They designed a reduced field of view EPI method using inner volume excitation to allow high resolution single shot acquisition of the plaque. We can see the ADC values in the lipid-rich necrotic core are significantly lower than the fibrous tissue. We extended the carotid ADC mapping to 3D using a diffusion prepared 3D TSE readout. We can see a clear vessel wall delineation at different V values as well as the ADC map. In the patients, we can observe a reduced ADC values in the region that potentially has a lipid core. So what's next? In my opinion, in our relentless pursuit of higher spatial resolution, patient motion during the scan will become a more prominent problem. A robust way to handle motion during the scan will be essential to improve quantitative imaging. One example is from Fostertel, where they showed the feasibility of using a navigator echo to keep track of motion during the scan and guide reacquisition if needed, and also use the navigator echo to correct the motion data using parallel imaging. There is a clear need for higher SNR and consequently higher accuracy and precision for the quantitative imaging techniques. And one way to achieve this is to design more sophisticated coils, as shown in this example by Beck et al., where they designed an interchangeable neck shape specific coil, where based on different neck shapes can provide the best fit. The closer the coil to the vessel, the higher the signal. Some final thoughts. So quantitative MRI is an alternative to multi-contrast MRI. It can reduce confounding factors involved in qualitative imaging and reduce the reliance on expert reading. It has the potential to eliminate the need for gadolinium and also facilitate application for automatic analysis and machine learning. In my opinion, the potential clinical applications could include the identification of culprit lesions, evaluating therapeutic responses, and also guiding revascularization. That's all. Thank you very much for tuning in.